Welcome back to Neph Bites. For the past 3 episodes, we've been living inside SIADH, diagnosis, mimics, treatment. We've built that framework carefully because SIADH is the most common cause of euvolemic hypotonic hyponatremia, and because getting it wrong is dangerous. But today, I want to introduce a group of disorders that are dangerous for a different reason. They look exactly like SIADH on the lab panel. Same low serum osmolality, same concentrated urine, same high urine sodium. A clinician scanning those results would say SIADH without hesitating, and then they'd reach for the standard treatment, fluid restriction. And that would be exactly the wrong thing to do. Because in salt wasting syndromes, the patient is volume depleted. Fluid restriction in a volume depleted patient makes them worse. It worsens cerebral perfusion. It deepens the hypovolemia. In certain populations, like subarachnoid hemorrhage patients already at risk for vasospasm, it can cause a stroke. The mechanism is completely different from SIADH. In SIADH, the kidneys are holding on to water inappropriately. In salt wasting, the kidneys are losing sodium inappropriately. The patient becomes volume depleted from that sodium loss. ADH kicks in appropriately in response to the low volume. Water is retained and hyponatremia develops. The ADH is appropriate. It's just responding to the wrong upstream problem. So the labs can be identical, but the physiology is opposite, and the treatment is opposite. Today we're covering 3 scenarios where this confusion most commonly causes harm. Cerebral salt wasting after subarachnoid hemorrhage, where distinguishing it from SIADH requires careful clinical detective work. Cisplatin-induced renal salt wasting, an under-recognized tubular toxicity that devastates oncology patients. And vomiting-associated hyponatremia, where the urine sodium will mislead you and the urine chloride will tell you the truth. Let's start with the hardest one. Cerebral salt wasting. Hyponatremia after subarachnoid hemorrhage occurs in over 50% of cases. You're going to see it constantly in any patient who has had a subarachnoid bleed. The majority of those cases are SIADH. We covered the treatment last episode. 3% saline, never fluid restrict. But roughly 6% of cases are something else entirely. Cerebral salt wasting, or CSW. And that 6% matters enormously because the treatment is opposite. SIADH, fluid restriction. CSW, volume expansion. If you restrict fluids in a patient who actually has CSW, you worsen the hypovolemia, reduce cerebral perfusion, and dramatically increase vasospasm risk. The distinction between these 2 diagnoses is one of the highest stakes differentials in hospital medicine. Let me walk you through a case that shows you how close they can look and what breaks the tie. Case 1. A 78-year-old woman, 1 week out from a traumatic subarachnoid hemorrhage after a fall. She's on nimodipine for vasospasm prophylaxis and isotonic saline. She develops headache and nausea, and her nursing staff notices her sodium has dropped from 137 on admission to 125. You go to examine her. Blood pressure supine is 145/88. Seated, it drops to 118/72. Heart rate supine is 98. Seated, 108. Central venous pressure is 3 centimeters of water, low. Labs: serum osmolality 260, urine osmolality 450, urine sodium 52. Uric acid is 2.6, low. Fractional excretion of uric acid is 25%, high. Phosphorus is 2.3, low. Fractional excretion of phosphorus is 20%. Now pause here. Look at those labs without the clinical context. Low serum osmolality, concentrated urine, urine sodium 52. That is a textbook SIADH pattern. If someone handed you that lab result without telling you about the postural hypotension, the low CVP, the tachycardia, you would call it SIADH and reach for fluid restriction. But the clinical exam is screaming volume depletion. So which is it? Here's the thing. Both SIADH and CSW share several lab features. That's what makes this so difficult. Both cause hypoosmolar hyponatremia. Both have concentrated urine. Both have high urine sodium. Both have elevated ADH levels. And both have a high fractional excretion of uric acid. So how do you break the tie? The first clue is volume status, which we've already noted. SIADH is euvolemic by definition. CSW presents with hypovolemia. The postural blood pressure drop and low CVP in this patient point toward volume depletion, though nimodipine, a vasodilator, can produce some orthostatic changes on its own. So volume status points you in a direction but isn't definitive here. The second clue is the fractional excretion of phosphorus. In the setting of hypophosphatemia, a fractional excretion of phosphorus above 20% has been specifically reported in CSW but not SIADH. The threshold is 20% and this patient is right at it. The third clue, and this is the most clinically useful one, is the saline challenge. The team gives a liter of isotonic saline over 4 hours. The sodium bumps modestly from 125 to 126, and the urine osmolality drops from 450 to 280. That urine osmolality response is the key. In CSW, giving volume corrects the stimulus for ADH. Once hypovolemia is relieved, ADH turns off appropriately and the urine dilutes. In SIADH, saline does not suppress the inappropriate ADH. The urine stays concentrated, and through desalination, the sodium may actually worsen. The drop in urine osmolality after the saline challenge favors CSW. It tells you the ADH was appropriate all along, appropriately responding to volume depletion, and that as you restore volume, the system normalizes. One more distinguishing feature worth filing away, though it's retrospective rather than acute. In SIADH, the elevated fractional excretion of uric acid resolves once the hyponatremia corrects. In CSW, it stays elevated even after the sodium normalizes. That persistently elevated fractional excretion of uric acid can help you confirm the diagnosis in retrospect, but it won't help you in the moment when you need to make a treatment decision. The treatment for CSW is isotonic saline to replete volume. Once hypovolemia corrects, ADH turns off and the sodium normalizes. Some patients with persistent renal sodium losses need ongoing salt supplementation. Let me anchor this before we move on. The saline challenge is both a diagnostic test and a therapeutic intervention. If the urine dilutes after saline, think CSW, keep giving volume. If the urine stays concentrated, think SIADH, stop the saline, manage accordingly. Now let's move to a cause of salt wasting that shows up in oncology patients and gets missed far more often than it should. Cisplatin-induced salt wasting. Most clinicians know cisplatin is nephrotoxic. Acute kidney injury from cisplatin is well recognized and something oncology teams watch for carefully. But beyond AKI, cisplatin can cause a chronic tubular defect that leads to ongoing, massive renal sodium losses, and this is far less appreciated. The mechanism is direct damage to the proximal tubular cell via organic cation transporter 2, inhibition of the sodium-potassium ATPase on the basolateral membrane, and possibly inhibition of the epithelial sodium channel in the distal tubule. The result is sodium pouring out in the urine even when the patient is profoundly volume depleted. The kidney has lost the ability to hold onto sodium appropriately. Let me show you what this looks like. Case 2. A 49-year-old woman with ovarian cancer, 3 cycles into a cisplatin and paclitaxel regimen. She comes in with postural dizziness, frequent urination, nocturia, and fatigue. On exam, orthostatic hypotension and tachycardia. She is clearly volume depleted. Sodium is 128. Urine sodium is 94. Fractional excretion of sodium is 6.3%. Creatinine is 1.1, up from a baseline of 0.6. Stop at that urine sodium for a moment. 94 in a volume-depleted patient. A healthy kidney in a volume-depleted patient holds on to every milliequivalent of sodium it can. Urine sodium should be below 20. Below 10 if the depletion is severe. A urine sodium of 94 in a hypovolemic patient means the kidney is broken. It physically cannot retain sodium. Now calculate the daily losses. Urine sodium 94, urine output roughly 3 liters a day. That's 280 milliequivalents of sodium lost every single day. Nearly 7 teaspoons of salt flushing out through her kidneys daily while she becomes progressively more volume depleted and hyponatremic. This is the hallmark of cisplatin-induced salt wasting. Hypovolemia with inappropriately high urine sodium and polyuria. The combination of those 3, high urine sodium, high urine volume, and volume depletion, should immediately make you think tubular salt wasting, not SIADH. Case 3. Same mechanism, different patient. A 60-year-old man with metastatic cholangiocarcinoma on cisplatin and gemcitabine. Syncope, polyuria, 3.2 liters per day. Grossly positive orthostatics. 4 kilograms of weight loss in 2 weeks. Sodium 127. Urine sodium 125. Urine osmolality 360. Daily sodium excretion 125 times 3.2 liters equals 400 milliequivalents per day. That is an extraordinary loss. This man is hemorrhaging salt through his kidneys every day, and his body has no way to compensate. The treatment for both of these patients is the same. Isotonic saline to replete volume, combined with a high sodium diet while the polyuria persists. If the cisplatin has caused permanent tubular damage, which it can, chronic salt supplementation may be necessary indefinitely. One pitfall worth knowing. Some of these patients have a component of osmotic diuresis layered on top of the salt wasting. You can calculate daily osmolar excretion, urine osmolality multiplied by urine volume. If the total is above 1,000 milliosmoles per day, there may be non-reabsorbed solute contributing to the polyuria. But in both of these cisplatin cases, the dominant driver is sodium loss. The math confirms it. The practical red flag for cisplatin-induced salt wasting is this. Any patient on cisplatin who presents with polyuria and hypovolemia needs a urine sodium checked immediately. If it's high in the context of volume depletion, you have your diagnosis. Now let's shift to a mechanism that looks completely different at the bedside, but produces the same diagnostic confusion: hyponatremia from vomiting. And this is where the urine chloride becomes the most important number on the page. Case 4. A 32-year-old woman with a history of bulimia. She's had nausea and vomiting for 48 hours. She's been drinking bouillon soup trying to feel better. In the emergency department, blood pressure 96/50, heart rate 102. Sodium is 120. She gets a liter of normal saline with 20 milliequivalents of potassium chloride. Afterward, urine studies come back. pH 7, urine osmolality 300, urine sodium 45, urine chloride 20. Look at that urine sodium, 45. You'd expect a volume-depleted patient, which she clearly is, with a blood pressure of 96 and a heart rate of 102, to have a urine sodium below 20. The kidneys should be avid for every milliequivalent of sodium they can find. So does urine sodium 45 mean she isn't hypovolemic? Does it point toward SIADH? No. And this is one of the most important pearls in this entire series. When a patient vomits repeatedly, they lose hydrochloric acid from the stomach. This creates a metabolic alkalosis. The serum pH rises, bicarbonate accumulates. The kidneys respond to alkalosis by excreting bicarbonate in the urine to normalize pH. But bicarbonate is a negatively charged anion. It cannot be excreted alone. It needs a positively charged cation to accompany it to maintain electrical neutrality. Sodium and potassium are the cations that get dragged out with it. So the sodium appearing in the urine isn't because the patient has volume excess or inappropriate ADH. It's because the kidneys are obligated to excrete sodium alongside bicarbonate to correct the alkalosis. The urine sodium is high because of alkalosis, not because of volume expansion. The urine chloride, on the other hand, is not affected by this process. Chloride follows sodium when the patient is truly volume replete. When the patient is truly volume depleted, the kidneys hold on to chloride avidly. A urine chloride below 20 means volume depletion, regardless of what the urine sodium shows. In this patient, urine chloride 20. That's low. That's hypovolemia. The urine pH of 7 confirms bicarbonate excretion is actively occurring. The rule: in any patient who is vomiting, check the urine chloride, not just the urine sodium. The urine chloride tells you the truth about volume status. The urine sodium will lie to you. This comes up on boards constantly. More importantly, it comes up at the bedside, and missing it means you give a volume-depleted patient fluid restriction instead of saline. That is a preventable mistake. And as a side note, her bouillon soup? That's actually appropriate management. A bouillon cube dissolved in a cup of water creates a sodium concentration of roughly 180 milliequivalents per liter. She was essentially self-administering oral hypertonic saline. Let me pull this all together into a 3-question framework you can apply anytime you see hyponatremia with a high urine sodium and concentrated urine. Before you call it SIADH, ask these 3 questions. 1. Is the patient volume depleted? Check orthostatic vitals. Look at the BUN to creatinine ratio. Assess skin turgor and jugular venous pressure. If volume depleted, think salt wasting, not SIADH. 2. Is there a cause for renal sodium loss? After subarachnoid hemorrhage, consider CSW. In any oncology patient on cisplatin with polyuria, consider cisplatin-induced salt wasting. Polyuria in the setting of hypovolemia is a red flag for a tubular defect. The combination should never be attributed to SIADH. 3. Is the patient vomiting? If yes, check the urine chloride before you draw any conclusions from the urine sodium. A low urine chloride with a high urine sodium and alkaline urine means bicarbonaturia is driving the sodium loss. The patient is truly volume depleted and needs saline, not fluid restriction. In every case, the treatment is volume repletion with isotonic saline. That is the opposite of SIADH management. And that is why getting the diagnosis right matters so much in this group. Next episode, we move to a completely different corner of hyponatremia, where ADH is suppressed and the kidneys are doing everything right, but the patient is still hyponatremic. Water intoxication, exercise-associated hyponatremia, and the low solute syndromes, beer potomania, tea and toast hyponatremia, and primary polydipsia. These are the cases where the urine is maximally dilute and the kidneys simply can't keep up. Thanks for listening to Neph Bites. I'll see you next time.